So veterinary laboratory diagnostic is very important aspect in veterinary practice. Laboratories fulfill essential role in delivering of veterinary services based on results of various laboratory tests and their interpretation, exact and confirmatory diagnosis is made. So today we have selected this topic, keeping in view the importance of laboratory diagnostic in small animal practice. So as far as speaker is concerned, Dr. Rajesh Kumar Banga is an alumnus of College of Veterinary Science, Ludhiana. He did his BVSc and AH in 1999 from this institute. He also served as assistant dean and assistant professor in College of Veterinary Medicine, St. George University, Canada. Dr. Rajesh is recipient of several national and international awards, including Carl Vinson Pfizer Distinguished Teaching Award. Besides, he has developed many teaching aids for benefit of veterinary students and veterinary practitioners. Presently, he is serving as associate veterinarian at Generation Pet Veterinary Clinic, Austin, Texas, USA. So we are thankful to Dr. Rajesh for sparing his valuable time for webinar presentation. Now I invite Dr. Rajesh to deliver the presentation.
Thank you, Dr. Bal, for your introduction and organizing this webinar. And thank you to Dr. Vishal Mahajan, also assisting Dr. Mandeep Bal in this webinar. So today's topic is interpretation of common diagnostic tests in small animal practice. And first, a disclaimer that I am not a specialist or pathologist. I'm a general practitioner working in a private practice. So webinar is mainly aimed at providing information for field level condition or for general practitioners. So I try to keep it very simple and practical, not including much theoretical part. And so let's start now. So common diagnostics that we use in a typical small animal practice in North America are listed in this slide. We have hematology, serum chemistry, hematology for blood cell count and PCV, hemoglobin, etc. Serum chemistry to look for the serum chemistry, then thyroid, coagulation panel, very, very important, urinalysis, fecal test to check for worms or other infections, radiography, x-rays as a diagnostic tool, ultrasound, again, very, very helpful, cytology, including like simple things like ear cytology, skin scraping, and also cytology of external masses, tumors, or internal organs like liver or spleen or kidneys. Then also we have SNAP tests like for heartworm test that also include Ehrlichia, Anaplasma, and Lyme. We have SNAP test for canine pancreatitis, feline pancreatitis that checks for pancreatic lipase, and also for parvovirus, giardia, some pregnancy tests. So there are a couple of SNAP tests. I listed some few here. So this is setup, diagnostic setup of a typical small animal general practice in North America. Some practices may have less than this, some may have more than this, but this is mostly what we have in general. And so for today's webinar, because it's a very, very vast topic, for today's webinar, we will limit our discussion mainly to the liver and kidneys, hepatic and renal diagnostics. And in also that I will try to keep it very simple and practical and some informative tips. So starting with the liver, the diagnostics used for liver, we check for liver enzymes, mainly ALT, AST, alkaline phosphatase, and GGT. AST, it is released from mitochondrial membrane of hepatocytes, ALT also from hepatocytes. Uh, AST mostly follows ALT, but AST indicates more severe damage. So for this presentation purpose, we'll skip AST, which is not very commonly tested here. We'll mainly stick to ALT, alkaline phosphatase, and GGT. In addition to these enzymes, we also check for bilirubin, bile acids, and ammonia. Bile acid, very important, very good test for liver. And also we check for ammonia. In addition to these, there are some other, many other diagnostics that help in diagnosing liver disease, including X-rays, radiography, ultrasound, splenic protogram. We specialists have a CT scan and other facilities also. Also, cytology or biopsy of liver is also a very important diagnostic tool. In addition to all these diagnostics, albumin, coagulation factors, blood urea nitrogen, etc., they are also important for diagnosing liver disease. So we'll go over them one by one. So liver diseases can be primary or secondary liver disease. It can be difficult to differentiate these two sometimes. Secondary liver disease is also called reactive hepatopathy, and it can distract us from the primary problem, from the primary disease. One very interesting thing about the liver is that liver enzymes can be very high in a normal dog with normal functioning liver, and they can be normal in a dog with very, very sick liver. So we'll go over some conditions that cause this. And so this makes diagnosis even a little more trickier. So main signs of primary liver disease. So we'll start with some radiographs. So one of the big sign of primary liver disease will be change in shape or size of liver. Change in shape, size, or conformation of the liver, we can diagnose with the X-rays and ultrasound. So this is a lateral X-ray of a dog's abdomen. And this is a normal shape of the liver, normal size of the liver. For the shape of or size of the liver, we go with the gastric axis. So from the spine, gastric axis should go either perpendicularly down or little caudal. This line indicates the diaphragm. So it should go either perpendicular down or little caudal. And that's a normal gastric axis. If it is less than this, it may be smaller liver, or if it's more than that, liver may be enlarged. And here you can see this is a liver. Margins are pretty good, nice and smooth. It's tapering good. And it's mostly staying in the rib cage. It's not extending too much beyond the rib cage, or it's not too much inside the rib cage. So that's a normal X-ray, lateral X-ray of a dog. And keeping this in mind, we'll compare some other abnormal X-rays now. So here you can see this gastric axis is going more cranially. If gastric axis is when we draw a line from fundus to pylorus, so that's gastric axis. So liver is very, very small here. So this is microhepatica. Microhepatica can happen in portosystemic shunt, very, very common, or hepatic cirrhosis, very advanced liver disease. Liver can be very small. Here, the gastric axis going from fundus to pylorus is very, very going to caudal. So this is obviously enlargement of the liver, and the liver is very enlarged. It's coming very much out of the rib cage, and this is hepatomegaly. Hepatomegaly can happen in many toxicities, and hepatitis can cause this, and chronic inflammatory disease can also cause enlargement of the liver. And in addition to increase in the size, shape can also be different. This is actually a liver lobe enlarged. It's a mass on the liver. which was confirmed with ultrasound. It can be confused with the splenic mass, so it's important to confirm it because of the location. Spleen also lies in this area. And so here liver size is looks normal, but it has very big mass attached to one of its lobe. This is a normal radiograph of a very young puppy. In younger puppies, the serosal details are lost. They are not very clear because their fat is not mature. Fat is what gives contrast in the radiographs. And liver is mostly bigger in younger animals, younger puppies. They have bigger liver, so this is normal. And here you can see it's tapering very nicely. It has sharp edge. That's how normal liver should be. In contrast, this is a liver from an adult dog. It is enlarged, but it has very round edges. This round edges mostly indicate some kind of neoplasia going on with the liver, mostly primary. It can be secondary, but mostly it is a primary neoplasia of the liver. Ultrasound, like we talked, is also very important. So here we see liver, here's the diaphragm, and ultrasound is very helpful to diagnose masses inside the liver, look into the gallbladder, any stone, sludge in the gallbladder. That's a very important diagnostic tool. In addition to change in shape and size of liver, there are many other signs of primary liver disease, like icterus or jaundice without anemia. That means it's either of hepatic origin or it's because of biliary obstruction. Hepatic encephalopathy, the nervous system signs, they mostly come from the primary liver disease. Acholic feces, that means white color of feces, it mostly comes from liver disease. Effusions of the body cavities, effusion in the body cavities, and sometimes with the liver disease, albumin goes very low, leading to decreased osmolality of the serum, and fluid oozes out into body cavities. Sepsis, so liver has very important function. It's a reticuloendothelial organ, so it functions as a filter, filtering the infection and all that from the body. So any sepsis it can be cause of liver disease. Coagulopathy is a very serious indication of a liver problem. It's serious because it can lead to disseminated intravascular coagulation. And usually when we see increased clotting factors, mostly 90% of liver is damaged and only 30% of clotting factors are remaining. Liver can also lead to some skin problems like this hepatocutaneous syndrome. Some of the causes of secondary liver disease, any systemic inflammation or infection can affect liver. Liver enzymes, liver values can be increased with these infections. Diseases of the organs drained by portal vein, these are mainly guts and the intestine, pancreas and spleen. They are drained by portal vein. Portal vein carries blood from these organs to the liver. That's the functional blood supply for the liver. And so any disease of these organs can also affect the liver. Hyperthyroidism in cat, severe muscle disease, unmanaged endocrine problems like Cushing's or hyperadrenocorticism and diabetes mellitus can also affect liver. Hypoxia, low oxygenation or congestion in the liver because of right-sided heart failure or hypoxia from anemia can lead to liver problems. And there are many drugs that affect liver enzymes. We'll go over some of those drugs. Steroids are most important of those drugs. So disease recognition in the liver. So mostly some of these factors are abnormal. There may be elevated liver enzymes like we talked, alkaline ALT, alkaline phosphatase and GGT. They may be affected. They will be higher. Low albumin, when low albumin because of liver disease is seen, mostly 90% of liver function is lost. Fasting hypoglycemia, mostly 70% of liver function is gone by if you see fasting hypoglycemia. Normally, body should have reserve and should be able to maintain normal glucose status. Similarly, postprandial hyperglycemia. So on fasting, glucose will go very down, and after eating, it will go up. So because liver is not able to convert into and store into glycogen, so that's why there is hyperglycemia. Low blood urea nitrogen. So the ammonia that is absorbed from the intestine is carried to the liver through portal vein, where it converts into nitrogen or blood urea nitrogen. So if liver is not functioning, there will be increased amount of ammonia in the blood and low blood urea nitrogen. Cholesterol and triglycerides are also affected. They may be increased. So interpretation of some of these enzymes. So ALT, increase in ALT indicates hepatocellular disease. So that means hepatocytes are affected. It can be from neoplasia, it can be from hepatitis or chronic inflammatory hepatitis or acute inflammatory hepatitis. All these can cause increased ALT. Any decreased perfusion of liver, decreased blood supply or oxygen supply to the liver can lead to increased ALT. For example, decreased blood pressure or hypotension, any congestion like in the heart failure or anemia lead to poor perfusion of liver and increased ALT. So ALT is normally present in hepatocytes, and because of any injury, it's released into the blood, and then we do the blood test and we see it increased, and that indicate trauma to the liver. Any trauma from accident or injury or from surgery or peritonitis can also lead to increased ALT. Toxicity, there are many toxins that affect the liver. Two most common we see here, in addition to some of the drugs, are sago palm trees and xylitol. They both are very, very toxic. They can cause very bad necrosis of the liver, and they need to be identified very early in the stage. Xylitol is an artificial sweetener that's found in many chewing gums, and some of the peanut butters here also sweetened with xylitol. Drugs, phenobarbital, very important, we use for the seizures, carprofen, anti-inflammatory, NSAID, and glucocorticoid barbiturates, and sometimes doxycycline I have seen increasing the ALT. Sometimes we put dog on doxycycline for heartworm treatment, and suddenly ALT is very high, and we stop doxycycline, and within 2 weeks or so, ALT comes back to normal. ALT, in addition to liver, is also produced by red blood cells and muscles. So any damage in the RBCs and muscles can also cause moderate elevation in the ALT, which does not indicate the liver disease. So this is one of the example where a liver enzyme can be high without any functioning alteration of liver. Next enzyme is alkaline phosphatase. Alkaline phosphatase, just like ALT is also in RBCs and muscles, alkaline phosphatase is also in the bones. So any bone disease can cause increase in alkaline phosphatase without affecting the functioning of liver. For example, any neoplasia of the liver, neoplasia of the bone, osteosarcoma also can also lead to increased alkaline phosphatase. Osteomyelitis, inflammation of the bones, hyperparathyroidism, growth of bone, and fracture healing. In the young growing puppies, alkaline phosphatase can be high, which is normal. It does not indicate liver dysfunction. However, alkaline is affected by many drugs, phenobarbital and glucocorticoid. Glucocorticoids can lead to increased alkaline phosphatase, but it may not affect the hepatic functioning. It may not cause any hepatic functioning or hepatic pathology. So it's very important to confirm it with bile acid, which is a test for liver function. Then many other liver diseases, particularly cholestasis diseases that cause stasis of the bile, either microscopic or gross, can also lead to increase alkaline phosphatase. Liver trauma and neoplasia, just like alkaline ALT, alkaline phosphatase can also be increased. Lipidosis in cats is very, very important. It's mostly high with the lipidosis, the alkaline phosphatase in cats with hepatic lipidosis. In addition to microscopic cholestasis, cholestasis from the excuse me, gallbladder or from the systemic diseases can also be increased. Gallbladder diseases like anything in the lumen, stones or sludge, mucocele, or in the wall, any mass, polyp, or outside the wall of gallbladder, anything pushing to cause the blockage or trauma or rupture of gallbladder will lead to increased alkaline phosphatase. Cholestasis because of systemic diseases like diabetes, hyperadrenocorticism, and also congestion and some other inflammatory diseases and infectious diseases lead to increased alkaline phosphatase. So this hyperadrenocorticism, which is also known as Cushing's disease, mostly it leads to very high alkaline phosphatase. Mostly we see like alkaline phosphatase of 900, 800, in this very high, like almost 4 or 5 times high than the normal values. So many systemic diseases affect the liver enzymes, alkaline phosphatase. GGT, it follows mostly alkaline phosphatase. It's increased to cholestasis. It's more sensitive to cholestasis. That means a little bit of cholestasis will cause more increase in GGT than alkaline phosphatase. But like alkaline phosphatase is not produced in the bone. So with any bone disease, it will not be increased. Only alkaline phosphatase will be increased. It's less affected by other diseases, liver diseases than alkaline phosphatase and ALT. So GGT is affected more by gallbladder or cholestasis. It can be elevated with the steroids. So because of this nature is sensitive to cholestasis, so it's very useful in dogs to identify the biliary disease. Some of the liver diseases that may have normal ALT and alkaline phosphatase. Some of the liver diseases, like we talked earlier, enzymes can be normal, but liver can be very, very sick. So one example is very, very end stage liver disease like cirrhosis, where there is not enough hepatocyte left to produce those enzymes, to secrete those enzymes. Hepatic lymphoma, these enzymes can be normal. Metastatic neoplasia of the liver, mast cell tumor, so it can be normal. Portosystemic shunts, mainly in the advanced stage, can have again normal ALT and alkaline phosphatase. Feline infectious peritonitis, feline pancreatitis, these can also have normal liver enzymes, but liver is not functioning well. Histoplasma, one of the fungal infection, can also, in the cats particularly, have normal liver enzymes, but liver can be very, very sick. Next test is bile acids. It's one of the best test for liver functioning. It's very, very good test to check for the gold standard for liver functioning, but it's not very specific because cholestasis can also lead to bile acid increase in the blood. So to do bile acid testing, we take a fasting sample, normally 12-hour fast, and then after taking that fasting blood sample, serum sample, we feed the animal a high fat food to stimulate the release of bile acids. And then we take another sample, serum sample, 2 hours later, 2 hours after the feeding, which will be postprandial sample. So because of this, if sample is already lipemic, it has a milky cloudiness in it, and we don't need to test it. Will be results will be skewed. They will not be normal. Similarly, if a patient is icteric, it has jaundice, we don't need to do bile acids because bile acids will be already high. You can see the yellow in the skin or eyes or in the mucous membrane. Also, do not test bile acids if gallbladder is removed surgically previously. Here is a link It's a very good link for interpretation of test for the bile acids. I have posted, I don't know if you can click and get to this link. I have also posted these links on this Facebook page, facebook.com/vet video. So you can get those links from there. And so we'll talk a little bit about bile acid interpretation. First, this is the normal schematic of liver enterohepatic circulation. So this is the systemic blood. Here is the intestine. Here is the liver. So these stars are bile acids. So bile acids are produced, stored in the gallbladder, and through bile duct, they are released into intestine. And they help in digestion of fat, and then after that they are absorbed back into portal vein. Some of them are absorbed back into the bloodstream, and through portal vein they are taken back to liver, where they are recycled and used again for the digestion. So this is enterohepatic circulation of bile acids. So they just keep on circulating here. So you don't see them much in the systemic blood. So there are some conditions where these will be increased in the systemic blood. One is decreased liver mass, if liver is not functioning, in other words. So it will release the bile acids into the intestine. They will be absorbed back into the portal vein, taken back to the liver. But because liver is not functioning, it will not be able to recycle these quickly. So they will leak out into the systemic circulation, and we'll see them increased after the fasting and after feeding. So this is because of the decreased liver function. Another reason for bile acids increase in systemic circulation will be portosystemic shunts, where this portal vein, instead of going to the liver, it shunts directly to the systemic circulation. It shunts directly to the vena cava. And so the reabsorbed bile acids from the intestine, they, instead of going through the liver, they go to directly to the systemic circulation. And it has two effects. One, liver is not able to work on whatever nutrients portal vein is, nutrients or toxins or other metabolites portal vein is bringing to the liver. And also these bile acids are high in the liver, in the systemic circulation. Another reason for these bile acids to be high in the systemic circulation will be any blockage of the bile duct because of any cholestatic disease. Blockage can be from bile stone, injury, tumor, like we talked earlier. So they will not be able to release into the intestine. They will accumulate in the liver, and bile acids will be absorbed through hepatic vein into systemic circulation, and we'll see them increased in the blood circulation. So bile acid is very, very important test, and interpretation is very interesting also. And so next liver diagnostic is bilirubin. So mild to moderate bilirubin in the urine is normal in dogs, but bilirubin in the urine is never normal in cats. So it can be used as a tool to monitor cholestatic disease at home in cats. Owner can use either a strip that changes the color, and usually with bilirubin urea or urine is yellow orange color. So bilirubin, if it increases more than 2 to 3 milligram per deciliter in blood, we'll see this yellow eyes, yellow mucous membrane, and yellow coloration of the skin. This is the normal range of bilirubin. I'm putting this so that in case in India we do use different units. So if they are very high, this is we'll see the yellow when they are increased more than 2 to 3 milligram per deciliter in blood. So that condition is icterus or jaundice, and icterus can be prehepatic, hepatic, and posthepatic. So prehepatic is mostly from hemolysis. Hemolysis can be from many diseases. It can be from immune-mediated hemolytic anemia, or it can be from anaplasma or other protozoal diseases that can cause hemolytic anemia. So here liver develops icterus because liver is not able to conjugate all the hemoglobin quickly enough, and it leaks out into the systemic circulation. So there is increased bilirubin in the, and usually PCB for prehepatic is less than 20% in cats and less than 25% in dogs. It's just a general figure that we usually see. In addition to prehepatic, which is hemolytic, the cause of icterus or jaundice. Next is hepatic reason. Any liver disease can cause icterus, and usually less than 10% of function is remaining. So liver has a very good regenerative power, so it can keep on functioning normal even if 80% of liver function is lost. That's why detection of these diseases very, very early is very important. Post-hepatic, that is mainly from cholestasis. If there is any blockage of the bile duct, bile is not able to escape out of the liver, it accumulates in the gallbladder, and bilirubin is absorbed in the circulation and leads to icterus. So ultrasound is very good test to differentiate hepatic and post-hepatic. Mostly we can see dilated bile ducts or is bile stone obstruction. And because this bile accumulation in liver, it is toxic to the hepatocytes. So post-hepatic icterus can lead to the hepatic icterus affecting the liver. Some of the toxins, hepatotoxins for the liver, is only some of them. There are more list than this, and some of the commonly used: acetaminophen, mostly NSAID used in people, anticonvulsants used, and many of the chemo drugs, arsenicals, and blue-green algae we see very often here. Carprofen, it is hepatotoxic. So whenever a dog is on carprofen for long-term use, we recommend monitoring of the liver values. Diazepam, if given IV in cats, it can be hepatotoxic. Chronic iron overdose. Griseofulvin is not used anymore as antifungal here, so but it is hepatotoxic. Some of the mushrooms that grow after rain, and they can be hepatotoxic. Certain household cleaners with the phenols are hepatotoxic, and some sulfur drugs can be hepatotoxic. But sago palms and xylitol, we see these toxicity quite a bit here, and maybe because it's very, very obvious, and they cause bad necrosis of the liver. This is the sago palm tree. They are common in India also. I've seen them, and here also they are very, very common. It's a very short palm, and mostly seeds are the most toxic one, but I have seen toxicity even dogs chewing on a dry bark of the plant. Similarly, xylitol, artificial sweetener, is very, very toxic for the liver. And so some of the take-home points from icterus is that if you see a cat with the increased bilirubin, but normal liver enzymes, like we talked earlier, ALT and alkaline phosphatase are normal, mostly we'll think of feline infectious peritonitis or lymphoma or pancreatitis or histoplasma. These can cause increased bilirubin, but normal liver enzymes in cats. This we don't see very often, but if bilirubin goes more than 20 milligram per deciliter, you can see some neurological signs, ataxia leading to seizures and renal toxicity also. Steroid hepatopathy and portosystemic shunt, they almost never cause icterus because there is a shunting of the liver, so they don't cause icterus. Slight elevation in bilirubin, very mild elevation in the bilirubin with other liver enzymes normal, and they are not very clinically significant. Mild bilirubin high can be normal, but it need to be significantly high. Lipemia and hemolysis can falsely elevate the bilirubin in blood sample from the testing. A few more conditions of the liver. Hepatic lipidosis is very significant problem in cats. Main etiology is starvation, when cats stop eating. along with some predisposing factors. One of the big predisposing factor is when they are overweight. If overweight cat stops eating, they may develop hepatic lipidosis, where some lipid droplets accumulate in the hepatocytes and they are not functional anymore. So cats are anorectic, because starvation is cause, and they may be icteric, mostly because of accumulation of fat. Hepatomegaly, liver is enlarged, and on a physical exam, you may be able to palpate the enlarged liver if a cat is not too overweight. All these enzymes, ALT, alkaline phosphatase, and GGT, are elevated, but alkaline phosphate is most elevated in the hepatic lipidosis in cats among these three. Ultrasound and cytology are the diagnostic tools. So here you can see a lateral X-ray of a cat with the liver extending way out of the um, rib cage. So this is enlarged liver because of hepatic lipidosis. On ultrasound, this is the falciform ligament and this is liver. So usually liver is hypoechoic compared to the fat. So it's darker than the fat and normal. But when there is hepatic lipidosis, when there is fat accumulation, you can see here, this is the falciform and it's hyperechoic compared to the fat. So it's more brighter compared to the fat. So that's indicative of lipidosis. And then cytology is a diagnostic tool. We can do ultrasound guided needle cytology. Mostly it's done from the left side because on the right side there is a risk of penetrating or rupturing gallbladder. And on the left side only we need to avoid spleen. And so this is the normal hepatocytes from a cytology and um, or needle biopsy. And here you can see in hepatocytes there are a lot of fat vacuoles, and that indicates confirms the diagnosis of hepatic lipidosis. So for treatment for hepatic lipidosis, main thing is feed the cat whatever you can feed. And there are some appetite stimulants like cyproheptadine, which is a antihistamine, mirtazapine, and their appetite stimulant. Also, propofol works very good at a lower dose. Normal dose is 4 to 6 milligram per kilogram IV. That's for the anesthesia for induction. But for appetite stimulant, we can use about 0.5 milligram per kilo IV, and it works very fast. So we need to hold the food in one hand, and as soon as we inject, give the food, and cat will start eating. And usually effect lasts for 30 minutes. So cat will have some appetite for 30 minutes. So this is one of the effort we can do. If these do not work, then cat may need a feeding tube. Usually we put esophageal feeding tube, and this feeding tube, if feeding to the cat leads to hepatic encephalopathy, that's a very poor prognosis, that chances of recovery are low. Next test is ammonia. Ammonia is also a very good test to diagnose a portosystemic shunt. Normal range, it's pretty increased in hepatic encephalopathy, and it can also be increased in hemolysis. So it's not routinely done if it's not available in the lab, because tests need to be run within 2 hours. If it's available in the lab, it can be in the in-house lab, it can be done. It's almost impossible to send out because mostly it's hard to get samples to a nearby lab in 2 hours here. But in India, some human labs nearby, if you can work with some, they may be running this, and it can be diagnostic. And this ammonia is toxic for nervous system, causing the signs of hepatic encephalopathy, neurological signs. Labradors are, I learned that Labradors are very common breed in dogs, very popular. There's a disease called copper storage hepatopathy. It used to be more prevalent in another breed called Bedlington Terriers, but right now it's becoming more common in Labradors. And mainly the signs are again liver signs. ALT will be high in the beginning, and later both ALT and alkaline phosphatase will be high. Liver biopsy with copper staining are indications of a copper quantification, which is done from um, a fresh biopsy of the liver. A veg biopsy liver can be sent. Mostly we send a frozen sample to the lab. Here some university labs do this test, and I don't know where this test is available in India. Some probably university professors can help with that. And usually it's more than 1000 microgram per gram dry weight of the liver. There is a company here. This is their website, vetgen.com. This company does genetic testing of dogs to check if they have a predisposition to develop this copper storage hepatopathy. So some of the causes that that these patients with the liver disease crash, so one of the most important is hepatic encephalopathy. Anything that triggers hepatic encephalopathy will lead to, not a very good prognosis of the for the patient. Sepsis is also not a very good sign. Overwhelming toxicity of that's causing hepatic necrosis, any abscess rupture in the liver, all gallbladder rupture can cause crash of the patient. Pulmonary edema from low albumin will lead to um, low perfusion in the liver, any bleeding or coagulopathy. Systemic inflammatory response syndrome, which is in very severe trauma, like very severe dog fights or hit by car cases, or sometimes sepsis or infection can also lead to systemic inflammatory response syndrome. So that completes the liver, and we'll continue with the kidney, some of the kidney diagnostics, and then we'll go over some cases, and we'll take the questions. So some of the renal values we test in the general practice are blood urea nitrogen, BUN, creatinine, phosphorus. SDMA is a newer test. It's available here with a lab called IDEX lab. I learned that IDEX may be opening some veterinary labs in India. So, so maybe pretty soon it may be available in India too, if it's not available so far. Then urinalysis is very important. You cannot properly diagnose a renal disease, a kidney disease, without doing urinalysis. Particularly specific gravity and sediment are very important. Here is a very good link from a clinician brief, one of the magazine, on a very simple article on urinalysis, interpretation of the result. This link is also posted on this Facebook page. Excuse me. So azotemia. Azotemia is increased blood urea nitrogen, creatinine, and phosphorus because of decreased glomerular filtration rate. So this is this increase of BUN, creatinine, and phosphorus is called azotemia. And usually 75% of reduction in GFR is required for azotemia to develop in the blood. To increase these values in blood, at least 75% of reduction of filtration rate. So uremia is azotemia plus related illness. Any other sickness that azotemia may cause. It may be PUPD, polyuria, polydipsia, increased drinking, increased urination. It can be vomiting, diarrhea, or combination of many other symptoms. That's called uremia. Indicators, early indicators of azotemia or early indicators of kidney disease. Before azotemia develops, the indicators of kidney disease are decreased glomerular filtration rate, obviously. Proteinuria, very important. You will see increased proteins in the urine. So that's why urinalysis is very important for diagnosing renal problems. Increased glucose in the urine without increase of glucose in blood is also indicator, early indicator of kidney disease. Sometime it can be some other factors like Fanconi disease or so, Fanconi syndrome. Urine casts more than 1 to 2 per high power field can also be indicator of early kidney disease. And isocynuria, some diluted urine can also be sign of. So this proteinuria is very, very important. And this IDEX lab developed this SDMA test based on that. This SDMA, which is a symmetric dimethylarginine, is a urine microprotein, and they developed this test which detect this SDMA in renal disease when only 25% nephrons are lost, whereas with azotemia to develop 66% of nephrons are lost, and GFR is reduced by 75% when azotemia develops. So this is very helpful in identifying the kidney problem, particularly in older cats. It's very helpful, and in dogs also very helpful. One of the specialist internists told in one of the lecture that it's not as reliable in cats as in dogs, but still it is something. It gives us some indication to work on the kidneys. There is a link for algorithm that's developed by IDEX labs to if SDMA is increased and how much it is increased and how to follow up, what to do next. So azotemia, increased blood urea nitrogen, creatinine and phosphorus. It can be pre-renal, renal and post-renal. So pre-renal is from any decreased blood flow to the kidneys that lead to decreased glomerular filtration rate. That can be dehydration or hypovolemic shock. It can be heart failure leading to less perfusion in the kidneys, or any other reason that there is less perfusion in the kidneys. It will be a pre-renal. Usually urine specific gravity is increased in pre-renal because kidneys are still functioning, but they are not getting enough blood. So it is increased. So it's very important to measure the specific gravity before we start fluid therapy for these hypovolemic or dehydrated patients. Otherwise, this specific gravity will be lower once their hydration is better. Then renal causes of azotemia. It is also from any disease that's causing nephron loss. We'll talk some of them. And urine specific gravity is usually, urine is usually isotonic, and it's 8 to 1030 urine specific gravity. And then post-renal cause of azotemia. This is a decreased glomerular filtration rate from obstruction of the urine flow. It can be from a stone, it can be from a polyp or tumor in the bladder or a urethra leading to obstruction, or a rupture of urinary bladder or rupture of ureter can also lead to post-renal azotemia, where kidneys are functioning normal, but body is not able to take the urine out. And eventually the post-renal also can cause renal azotemia to certain degrees in certain conditions, particularly obstruction from the backup of urine, in simple language, can affect the kidney. So there's some conditions where you will see increased blood urea nitrogen and normal creatinine. This can be from increased protein in the intestine from either high protein food, a recent high protein meal, or GI bleeding that leads to production of ammonia, and this ammonia is absorbed and taken to liver and converted into blood urea nitrogen. So you will see increased BUN with normal creatinine. It's not indicator of a kidney disease or kidney dysfunction, but it's just normal increase. Fever, high fever can lead to increased BUN. Certain drugs like tetracyclines and glucocorticoids also leads. And sometimes even early pre-renal azotemia with mild dehydration, you can say, you will see increase of BUN but normal creatinine. So creatinine is decreased normal in puppies because they have low muscle mass and their glomerular filtration rate is high. Any severe muscle loss or cachexia can lead to decreased creatinine. Yeah, so these are not clinically very significant, and increase in creatinine and normal VUN is not very common, so you can skip. It's mostly from muscle trauma, and that lead to increased creatinine. Creatinine is released from the muscle like myositis, or even after cooked meat meal, creatinine may be a little high. So let's do some clinical cases. This is a Harley. Harley was a 5-year-old spayed female, blue heeler breed, presenter for vomiting, bloody diarrhea, and polyuria, polydipsia for a few days. On physical exam, pet was dehydrated and no other significant finding. On CBC, PC was increased. Everything else was normal. On chemistry, blood urine nitrogen was increased, and the starred values are normal values. Creatinine was increased and phosphorus was increased. There was a low sodium and high potassium, and this was the sodium potassium ratio. Urine specific gravity was isostheneuric, and quick abdominal ultrasound was normal on this pet. It was treated with the IV fluids. In 2 days, azotemia and electrolytes were normal and back to normal. We started on phosphobinder, aluminum hydroxide orally, and ampicillin was given. Responded very nicely to treatment, sent home, but returned in 10 days with a similar presentation. So differentials at this stage for Harley are chronic renal failure or hypoadrenocorticism. So a ACTH stimulation test was performed. In ACTH stimulation test, we give cortisone. We take a pre-ACTH sample, and then we give causentropin hormone, which acts on adrenal cortex, and takes another sample 1 hour later, which is a post sample. So normally this causentropin hormone, it acts on adrenal cortex, causentropin, and so there should be stimulation of adrenal cortex, and it should release cortisol. So because there is not much increase, there is hypoadrenocorticism, because this hormone was not able to stimulate the adrenal cortex. So hypoadrenocorticism is also called Addison's disease. It can have many different presentations, and is called great pretender for the same reason. It can pretend to be like any other disease, and can be tricky sometimes. Addisonian disease, they respond very good to dexamethasone, and if dexamethasone is given before this test, it doesn't interfere with the test result or interpretation. And but if prednisone is given, it can affect the results, and normally labs recommend withholding prednisone for at least a week or so before we run this ACTH stimulation test. Long-term management with the desoxycorticosterone or any mineralocorticoid injection. Here a trade name Percortin is available. It's given at monthly interval, and mostly we monitor electrolyte, sodium potassium ratio, and PGPD at home. Once everything is controlled, PGPD at home will be normal. 90% of Addisonians have a high blood urea nitrogen, and sodium potassium ratio less than 25 is a classic sign, but not diagnostic. Diagnostic is the ACTH stimulation test. Next in renal values is phosphorus. Low phosphorus can be very dangerous. It's needed for stabilization of RBC membrane. So if it is low, it can lead to hemolysis and some neurological signs. If there is some mild hypophosphatemia, not very severe, it can, along with the hypercalcemia, very high calcium, it is mostly because of the neoplasia. It's hypercalcemia of neoplasia. That's the number one reason for hypercalcemia and low phosphate in dogs. Mostly lymphoma, anal gland adenocarcinoma are very common. Other reasons for hypercalcemia are also Addison's disease, which is the second most common reason for hypercalcemia in dogs, and hyperparathyroidism is also any tumor or increased functioning of parathyroid hormones mobilize the calcium out of bones, leading to increased calcium in the systemic circulation. Another case, clinical case, this is Hank. Hank is a 6-year-old neutered male Labrador presented for regular dental cleaning because obviously some gingivitis, and client complained about bad smell from the mouth, halitosis from the mouth. Pre-surgical blood work indicated increased blood urea nitrogen, increased creatinine, and increased phosphorus. Urine specific gravity, isostheneuric. On the sediment, we saw white blood cells, about 15 per high power field, some granular cast sealed, and no bacteria seen. So there is azotemia with the isosthenuria and some granular cast. So it's a renal azotemia. On physical exam, there was some discomfort, some pain on the palpation on the lumbar region on the spine where the ribs end in that area. On abdominal ultrasound, there was no corticomedullary distinction in the kidneys. Renal pelvis was dilated and kidney was smaller in the size for the dog. And so we opted for a urine culture because of white blood cells in the urine, and leptospirosis titers, because leptospira can lead to increased renal values. And while waiting for the treatment, for the results, we started with amoxicillin. Ampicillin is also a very good choice for antibiotic. So urine culture was negative, and leptospirosis titers were as indicated. So this leptospira autumnalis was 1:1600, which is pretty high. This is not included in the vaccine. Leptovaccine includes 4 strains: Pomona, Icterohemorrhagia, Gripotyphosa, and Canicola. And so this pet was vaccinated. That's why we see increased titers in the other serovars also. But autumnalis was causing the disease. So Hank was having pyelonephritis caused by leptospirosis. It was treated with amoxicillin and doxycycline, and azotemia resolved in 30 days, and eventually his teeth were cleaned. Ampicillin is also a good choice, and doxycycline is antibiotic of choice to eliminate the carrier stage or shedding of the leptospirosis by dogs. So take home points from Hank. Some of the tips are that halitosis and gingival ulceration, sometimes that can be presentation from the clients. Clients can come, they may not see slight weight loss or polyuria, polydipsia at home, but that bad smell from the mouth or bad gums that are actually happening from uremia. This is called a uremic halitosis, can be the presenting complaint. A negative urine culture does not rule out pyelonephritis. So that's inflammation of the renal pelvis. It can still happen even if there is no growth on the urine culture. And leptospirosis can cause renal failure and hepatic failure. It affects both kidneys and liver. And vaccinated pets can still get leptospirosis because there is no cross protection. There's no cross immunity among the serotypes. Next diagnostic we'll go over is the renal biopsy. We are almost done, just a few more minutes. Contraindicated for small irregular kidneys where there is decreased corticomedullary distinction. It can be chronic renal failure, and in chronic renal failure there will be anemia from lack of erythropoietin. Renal biopsy is indicated for enlarged kidneys, but sometimes ethylene glycol toxicity, which is an antifreeze used in cars, we should not do renal biopsy on that. It can further precipitate renal failure. So this is some ultrasounds of renal of kidneys. So this is a normal kidney. You will see cortex and the normal medulla and renal pelvis. This is chronic kidney disease. The distinction between cortex and medulla is gone. This is pyelonephritis in dilated pelvis, and this hyperechoic area, this indicates the inflammation in the renal pelvis. And here, this area is called medullary ring. This medullary ring is formed in ethylene glycol toxicity. There are some other tests, and you can see calcium oxalate monohydrate crystals also in the urinalysis with the ethylene glycol toxicity. But on the ultrasound, this is a very classical sign. One last case, this is Bell's, which was very young cat, 8-year-old spayed female cat, presented for not doing good at home and losing weight over past several weeks. Was very, very underweight on physical exam, and abdominal palpation revealed an abdominal mass. Blood work was no significant finding. Mostly it was normal. A lateral X-ray ultrasound of, radiograph of the abdomen revealed a large abdominal mass as indicated by these boundaries. Here is the urinary bladder, and here is the one of the kidney, and rest of the intestine, liver, and other organs. This is the VD, ventrodorsal projection of Bell's abdomen. And on the left side, it was all covered by this mass, and pushing all the intestine to right side, and some to the cranial. And a quick ultrasound revealed that this is originating from kidneys. So with the owner's permission, we decided to explore. A surgical laparotomy was performed, and some punch biopsies from the enlarged kidney was found. So this is, you can see during, just before the surgery, you can see that mass protruding from the abdomen. So histopath of those punch biopsies indicated lymphoma, and it was large cell type lymphoma. Because of the poor body condition and poor prognosis, owner did not elect for chemotherapy, and Bell's was euthanized a few days after surgery. So that was kind of sad ending. But take home lesson is even with the kidney tumor, the blood work was normal. So because there are two kidneys, other kidney was able to take up the function of, all the renal function, but still cat was feeling sick because of all that lymphoma and cancer going on in the body. For more clinical cases, please visit this website. I will post this also on Facebook later. This website has about 25 clinical cases and pretty good explanation. The cases are a little older, but they still stand true today. And acknowledgements to Dr. Wendy Blunt and Generation Pet Hospital for their resources and times. And thanks again for the organizers, Dr. Mandeep Bal and Dr. Vishal Mahajan, for organizing this webinar. Any questions we can talk now, or you can ask by email. Here's my email displayed on the screen. Thank you very much. Back to you.
Thank you, Dr. Rajesh, for a nice presentation. I understand laboratory diagnostic is a very vast topic, and Dr. Rajesh Banga covered or summarized very excellently important biochemical tests, especially for liver and renal damage. So because of shortage of time, actually students have to join another classes. So that's why we are not taking much of the questions. So you can email to Dr. Banga. Dr. Banga will answer your question. And thank you very much, Dr. Rajesh. Once again, very nice presentation. Thanks all participants and other coordinator of IDP for giving opportunity to Dr. Banga. Thank you.
Thank you again.